tell us how could CDK4/6 inhibitor make the difference. Dr. Saadeddin, please.
Thank you very much, Dr. Nafisa, again for the invitation and for the nice arrangements. I hope I will stick to time. I'm going to share my screen now. So, am I well seen now in the?
Yes.
Okay. So I hope in the coming 20 minutes, I'm going to fly with you quickly whether this medications or this group of medication is with us to stay or to go away. Let's see. That is some disclosure slides. These are, things which we are going to hopefully go through quickly. People who knows me know I love this slide. We are a team and we always have to make sure that we have the right team with us. And pathology, surgery, radiotherapy, and so on are really very important, stones in this circle, which has to be complete to have a good service. I'm going to start with story of two patients. Then I present one of my patients in 1988, where I've just joined oncology the first year. I still remember Nof, who was only 39. She had 3 children. Her diagnosis was only 2 words: memory carcinoma after an FNA. She had CT scan, which showed lung, liver, and bone metastases, had no response to AC chemotherapy, which was very trendy those days, shifted to CMF, no response, died within 5 months of diagnosis. I still remember her face. Last week, I've seen this lady who is now 42. She was diagnosed with similar sort of scenario in 2013. She's a sister to one of my dear colleagues who was started on chemotherapy elsewhere. She had a luminal breast cancer. Then she said, I prefer to die, not to go on with chemo. She was giving taxanes, docetaxel plus, I think, cabo or something else. It was very toxic to her. So she came to us and we started her on systemic therapy, non-chemo, basically hormonal therapy plus, we started with double hormonal at that time. Now we shifted to fulvestrant. Her last 2 PET-CT scan did not show any activity. And, we have lived the journey between these 2 stories, and thanks for the revolutions which have happened in breast cancer understanding and management. This is a patient whom I'm still seeing, young, 34. She had 3 children, negative family history, left breast cancer, which was multifocal, luminal with lymphovascular invasion and Ki-67 of 15%. Query M1 with lung nodules, suspicious, and left supraclav lymphadenopathy. She had a BRCA because she is young, and it was positive for VUS, variant of unknown significance. Her bone scan was basically negative, and we have seen her in October, 2019, just before the break of Corona. So we decided at that time to start her on the combo of AI plus LHRH plus Balbo and the usual things. Then we have realized that she was had a very poor compliance to her therapy because of many things. She is a difficult lady to obey commands. I'll tell you what happened to her in a minute, but I believe we have lived 5 revolutions in breast cancer, and today we are going maybe to touch on the one in luminal breast cancer, which started in 2015. Again, I always think of breast cancer as a systemic disease, and this is a fact which has been noted to since 1975 in the Lancet by Diana Bradley and John Hepitel, two physicians who followed stage 1 breast cancer for 25 years, and they have realized that less than 20% were alive only at that time. So the story of adjuvant therapy, whether hormonal, chemotherapy, and so on, started since then and actually had made the difference. The other revolution was in the understanding that there's nothing called breast cancer. Please tell me, what are we talking about before we start talking about prognosis and treatment? So it's very important that we know now on molecular biology, what are we talking about? Many treatments have been seen. We started with AI after tamoxifen. mTOR inhibition came down the way, but CD4/6 really was the major class of medications which jumped into the playground, and it really it seems that it's making a difference and it's here to stay, and we'll see how. So we started to correlate between morphology and molecular biology through ERBR, HER2, and Ki-67 scoring, and we have seen the difference in prognosis and the way we approach, to the extent that even at San Gallant since 2011, almost 10, more than 10 years ago now, the luminal A, B1, and B2 with the specific sort of definition has been alluded to, and it's available for everyone. Simply because they are two different diseases. When it comes to probability of recurrence, luminal A is nothing like luminal B, and it's clear from this diagram that we have good and bad tumors, which is it reflects how much is it estrogen-driven tumors. Of course, luminal A is mostly E2-driven malignancies. For a long time, tamoxifen and letrozole have been tried, and both are good, and we initially sort of accepted as a better medication based on PFS, and these trials have actually included HER2 positive and negative diseases at the time, and we know now they are totally two cohort of patients. The best thing we have achieved, as I've mentioned previously, was around 10 months with monotherapy and up to 15 months in a study with combination of fulvestrant plus AI. We were stuck with these numbers for many, many years. Then we wanted, one way out of this. It was really tough to see luminal disease, which is progressing, because the only option you had at that time is to go for chemotherapy. And usually it's not a good scenario, after that. The first thing we have learned that we need to differentiate between HER2 positive and HER2 negative disease. HER2 positive on hormonal therapy alone, they do much worse, while HER2 negative, they do better. So, we started to know since 2011 that HER2 positive has to be treated differently, even if they are ER positive. And that was something we have learned. Then the new medication came, like fulvestrant, and the trick was to concentrate on endocrine sensitive disease, not on the everybody. And the story of sensitivity was addressed at many conferences and societies. Dosing of medications, the story of fulvestrant is very clear that 500 was the one which was superior to AI. And the thing about this drug, that it did not touch the primary resistance. The main effect was on the secondary resistance of that one. And this is maybe related to the ESR mutation, which develop across the time during the course of metastatic disease. So if you have a muted or mutated ESR, then fulvestrant might make a difference. But if it's still a wild type, exemestane was as good. And that was, again, a learning things for people who were doing breast cancer. Eventually, we learned much more that, it's not only the ER pathway which plays a role. There is growth factor pathways, which includes PIK3CM, mTOR, AKT pathway, which eventually actually talk to the ER pathway, and sometimes you get a proliferation of the tumor in spite of having ER being not activated. And this was really a revolution, I think, in the understanding of luminal breast cancer. We always were under the impression that if you block the receptors of estrogen, or if you stop the production of estrogen, the luminal breast cancer should respond. We know that it was not the case in all cases, but we know why not. And that was, to me, a scientific revolution, discovering that crosstalk between these two pathways, which opened the door for a lot of medications, which really have made a clear difference in the outcome. Polira-2 is not, I'm sure it's well known to all of you, where everolimus have been added to exemestane compared to exemestane alone, and look at the curves, fantastic difference between the two. We had problem with toxicity of this medication, but nevertheless, it was a scientific revolution of the understanding of breast cancer. PIK3CA mutation as well was, if you add it to fulvestrant in the second line compared to hormonal therapy alone, it has made a big difference. I'm going to allude to that more in the later on. The other thing was the CDK4/6 inhibition was again another revolution. So we had really doors which have been clearly opened in luminal breast cancer. All of a sudden, within a short period of time, within 1 or 2 years, literature was flooding with information about alternative pathways to deal with breast cancer. What is beautiful about this one is actually the complementary and even synergistic effect between hormonal therapy and CDK4/6 inhibition. Without going into a lot of details, that was shown in the preclinical data. And as you are all aware, we are all extremely busy learning and sort of applying the knowledge we have learned from the Palomas, Mona Lisas, and Monarch and solar studies in our clinics. So really busy but beautiful time. This is also summarize, our understanding of the treatment in the first line, treatment in the second line for primary resistance and secondary resistance, and so on. In the first line setting, you are all aware of the major difference which has been made by the 3 medications. It looks like a mirror image. Is unbelievably potent, consistent, continuous across the trials effect, proving that this is a very important class of medication. Again, I strongly believe it's here to stay. Look at the PFS hazard ratio. It's almost like a mirror image, 0.5, 0.5, 0.5, whatever the way you look at it. Very consistent and impressive in all group of patients. You cannot actually confidently say that any patient will not benefit from the combination in the first line. And the beauty of also these medications compared to the other ones, that it was addressing the primary resistance as well as the secondary resistance. So it is a beautiful drug which changed the biology of the disease itself. Look, the curve started to separate from the outset, indicating a significant and meaningful change in the biology of cells from the beginning. And these are the curves of PFS of Paloma-2, again, very clear, Mona Lisa 2, extremely clear separation, and Monarch-3 addressing the same sort of patients in the first line setting. Not only this, the Mona Lisa 7 in the premenopausal have shown survival advantage, which we don't usually see and would love to see, as I always say, in metastatic setting. And it will really drive the change strongly when you see a survival advantage. So we have seen it in Mona Lisa 3 as well in the first line, and in the second line, maybe it's not as good, but it's not that significant. But in the first line, it was more impressive. Now, in second line, the CD4/6 inhibitors was also clear from Paloma 3 and Monarch 2 data, and Monarch 1 as monotherapy. Again, look at the PFS. Very clear separation of the curves from the beginning, whether it's Monarch or Paloma's 2. Again, the PFS is 16 months. Remember, we were talking about 10 months with mono. Now we are talking about 16.4 months. And as I was talking to, the hint of survival advantage is on Mona Lisa 3. What was impressive in the second line, clearly actually, was the survival data of the Monarch 2, where the p-value was significant, clearly with a good difference, almost 10 months difference in overall survival. That was, it is very impressive data in the second line when it comes to survival with the combination as a second line. Very impressive one. Back to our patient, based on this data, she presented to be seen physically on 17th of February during COVID. After we called her, she said, I'm not well. And when we examined her, we found clinically local progression in the breast and axilla, which was proven by ultrasound and mammography, and unfortunately CT scan have shown supraclav, left subpectoral lymph nodes, hilar lymph nodes, and some fissure nodules concerning for metastatic disease. She was on Balbo. She was not really very much into it. She was on Balbo and letrozole, and we have very little data of what to do next. What we have tried to do, is to get NGS, but we could not. It was really tough. She was not at all even contemplating the idea on chemotherapy, and the only thing I had in my hand at that time, get some water, is to change hormonal therapy to fulvestrant, keep her on Balbo, and ovarian suppression, March 2020. In August, 6 months later, that lady was very difficult to follow, frankly. She was seen with liver mets. Okay, her disease locally was not that progressive, but her, as you can see, CT and MRI had confirmed the presence of liver mets. I wanted to see whether I'm still dealing with the same pathology, so I managed to have a liver biopsy which showed non-cirrhotic liver tissue with metastatic adenocarcinoma. ERPR still strongly positive, HER2 negative. Chi was not done on her. When we questioned her about really the compliance with therapy, I was not impressed. And again, she was not keen on chemotherapy. If she, even without suggesting that, she said, forget about chemo, I'm not going to consider it. And we had no much alternative. NGS was not done, so I don't know about her PIK3CA status. So I've opted to actually change this time the biological therapy. So I kept fulvestrant with ovarian suppression, and I started Abema. And I stressed to her that we need to see her on a monthly basis to follow her side effects and see her compliance. And luckily enough, we started to see some response in her CA125 nicely. And her drop in white count was not an issue. Her diarrhea was not an issue. So, she was really happy to continue. We have scanned her in May 2021. There is, as you can see, reduction in the size of liver mets, and there is no new lesions. And her PET CT scan actually was on the same line. There was some thyroid uptake, which we did FNA from, and it became negative for malignancy. But we still yet seeing multicentric breast disease and some lymph nodes. Clinically, she is perfectly well, and it's our future plan to continue with the same management with dose modification if needed. I have now many patients on Abema, and I think most of them sometimes require dose reduction to 100 milligram daily BD at some occasion. So we will biopsy progressive disease to check for NGS and specifically PIK3CA mutation. Of course, we'll consider chemotherapy if needed, and even local radiation therapy for any refractory local disease. And usually, I don't really give up easily in young patients who have a good performance status. This is the most recent advanced blood cancer guidelines, which actually still state that the optimal sequence is uncertain, and available options, as I've mentioned, AI plus CDK4/6 inhibitors, and it does not specify anyone, and it will sort of consider alpelisib, the pan-PIK3CA mutation patients, plus fulvestrant as a second line as well, with really very high recommendation score. And this is the way I think about my patients in the clinic whenever I have the ability to. I'm actually started to request for PIK3CA mutation at the outset. If there is a mutation, I don't start with fulvestrant. I start with AI plus CD4. And I keep alpelisib plus fulvestrant. Alpelisib still, we have to request it as non-formulary for a second line. If there is visceral crisis, of course, we always go for chemotherapy. But if the PIK3CA is wild type, now maybe fulvestrant can be considered. Keeping mTOR inhibition plus exemestane as a second line, or chemotherapy. I think we will learn more about this in future. PARP inhibitors, if BRCA mutant, is also things to be considered. We don't yet ask for any BDL1 testing for luminal breast cancer, but I think we are learning about that in the future. So there's a lot to be learned still about the best sequencing in ER positive breast cancer. And I again stress that the class of medications, whether mTOR inhibition or CDK4/6, are here with us to stay. The mTOR inhibitors have actually moved mostly to subsequent line of therapy because of toxicity, and CDK4/6 becomes almost the standard of care for most patients. Thank you very much.